All right, so here's a story that's all about good intentions gone a little sideways. We're talking about a medical update, one that was supposed to make lung cancer screening way smarter, way safer for patients. But as it turns out, it had a side effect that nobody saw coming. Sounds like a total paradox, doesn't it? How can a rule change designed to stop unneeded tests actually cause more of them? Well, a recent study dug into the lung cancer screening guidelines and found that, yeah, that's exactly what happened. It gives us this really fascinating look at how we as humans can interact with even the best laid plans. So let's get into it. Okay, so to really get what happened here, we've got to start with the basic challenge of lung cancer screening. These low-dose CT scans, they're amazing. They absolutely save lives. But they've got a pretty significant downside, and that's the problem of false alarms.
And the scale of this problem, it's kind of startling. One study found that around 13%, think about that, 13% of all the findings on these scans are false positives. These are spots or nodules that look scary. They look suspicious. They trigger more tests. But in the end, they're totally harmless.
And we have to remember, this isn't just a statistic. Every single one of those false alarms has a real human cost. It's the gut-wrenching anxiety for a patient who's now worried they have cancer. It's more tests, more scans, which means more radiation exposure. And, yeah, it means higher costs for everybody. So you can see why trying to cut down on these false alarms is a massive deal. So to try and get a handle on this, doctors basically needed a playbook. A standardized set of rules so that a suspicious spot found in one hospital is treated the exact same way as one found across the country. And that playbook, it's a system called Lung-RADS. Yeah, you can think of Lung-RADS as basically a risk scoring guide. It helps radiologists put what they see into different categories, from nothing to worry about all the way to highly suspicious. And then it gives them super clear instructions on the next steps. It's all about making things consistent and precise. Now, this system isn't set in stone. It gets updated all the time as we learn more. And back in 2022, a pretty important update came out. The key part for our story is a change that was specifically meant to deal with those tricky findings, the ones that look like they might just be a temporary thing, like an infection. Okay, so the change itself seems really subtle, but it turned out to be critical. The old system had this category 4B for some big nodules that could be an infection. The new system swapped that out for category 0, which was for any findings that were suggestive of an infectious process. See that? The wording got just a little bit broader, a little more open to interpretation. And look, the goal here was fantastic. The whole idea was to give doctors a better way to say, you know what, this looks like it's just a temporary bug. Let's not freak out. Let's just do a short-term follow-up instead of jumping straight to more invasive stuff. The whole point was to do fewer unnecessary tests. Right, that was the plan. But when researchers actually dug into the data to see how doctors were using these categories in the real world, they found something that no one was expecting. So here's piece number 1 of this puzzle. This new category 0, it was being used twice as much as the old category it replaced, double the usage. Radiologists were suddenly flagging way more cases as, hey, this might be an infection than they ever did before. Just to be clear, under the old rules, that category 4B was usually for new, pretty large, solid-looking nodules. The kind of thing that definitely makes you pay attention and raises a bit of concern. And that concern was for good reason. It turns out that of all the cases that got flagged with that old category 4B, a full 22% of them were actually cancer. So, yeah, that category was doing its job. It was catching real, dangerous cancers. Okay, so now let's look at the new category 0. With this one, radiologists started applying it to a much wider variety of things, including these kind of hazy, fuzzy-looking spots we call ground glass opacities. And here it is. This is the big reveal. Despite being used twice as often, you want to guess how many of the new category 0 cases turned out to be cancer? 0. Not a single one. Zilch. So let's just process that. A tool designed to fine-tune the process and reduce tests was now causing double the follow-ups, and all of them were for harmless finding. So what in the world happened? How did such a smart, well-intentioned update go so wrong? Well, the crazy thing is, it wasn't really a problem with the guideline itself. It was all about how it was being used, and the data tells a very clear story. Let's take a look at what was actually getting lumped into this new category 0. You can see a massive chunk, 43%, were those hazy ground glass nodules we talked about. And then another 13% were these tree and bud nodules, which are also a classic sign of inflammation. And right there, that's the heart of the problem. If you add those up, 56% of the cases were for those ground glass or tree and bud nodules. And here's the irony. The new guidelines specifically said that for those exact findings, you probably don't need a short-term follow-up. You could just wait for the regular annual scan. So the tool was being used for the very things it was meant to help doctors avoid. So what's the big picture here? Look, this isn't about blaming anyone. It's about learning a really powerful lesson about what it takes to actually make healthcare smarter and better. There was an editorial that came out with this study, and this quote just nails it. It reminds us that every single one of those extra unnecessary follow-ups has a cost. It costs patients their peace of mind, it costs the system real money, and it can even undermine people's trust in the screening programs that are supposed to help them. So what's the lesson? It's not just about this one rule change. What this whole story shows is that inventing better tools is only half the job. The other half, the human side of things, how we actually use those tools, is just as important, maybe even more so. To get it right, you need constant training, constant feedback, making sure that every new breakthrough is actually helping patients like it's supposed to. And all of this leaves us with a pretty huge question for the future of medicine, right? Our tools for seeing inside the human body are getting unbelievably powerful. So how do we make sure that as we get all this new power, we're also building the systems to ensure it's always used with the precision and, frankly, the wisdom that it demands?